Hello, everyone, and welcome to this special seminar from the Alberta Transplant Institute. I'm Lori West. I'm the director of the ATI, and it's a pleasure to see names popping up that we haven't had a chance to see in a number of months due to the pandemic precautions. I'm very excited about today's lecture and about having you all here. Just a note that we are recording today's seminar, so please make note of that. And we'd ask that you keep your cameras off during the presentation. And then at the end, we'll have a chance to have a Q&A. So I'm going to turn over to Hetham, our cardiothoracic fellow, to introduce today's speaker, Dr. David Weill. Go ahead, Hetham.
Thank you so much, Lori. Thank you so much. It's a great pleasure here to be with you all today, and it's an honor to have our distinguished speaker, Dr. David Weill. So David is a transplant physician by profession. He is the former director of the heart-lung transplant program at Stanford University Medical Center. It's one of the world's most pioneering and successful transplant programs, where actually the first adult heart transplant in the United States took place in 1968 by Norman Shumway, and the first combined heart-lung transplant was performed there in 1981. So he was the leader for that program for a number of years. And after being in Stanford, I think for 10 years, leading one of the most successful programs in the world, David went through a turning point in his professional and personal life, where he actually decided to retire from his transplant medicine career. In his recently published book, Exhale, David sheds light on a lot of challenges that frontline healthcare workers face on a daily basis. David comes today actually in a very extraordinary time where a lot of healthcare workers, frontline workers, are faced by unprecedented challenges. So please join me in welcoming our guest, David. It's a great honor to have you here, David.
Thank you. Thanks so much for having me. And I also want to thank Dr. West as well, whom I've known for a long time and is a real leader in our field. And it's a real pleasure to be here today. All right. So thank you again. I'd love to be there in person with you folks in Canada, but here we are. So most of the time when you hear a talk by somebody that's recently published a book, most of the talk is about the author. But this talk is really about you and me. It's about the experiences that we have doing the kind of work we do on a daily basis. And for the more scientifically inclined, I'm afraid there's not much science in this one, but more of a humanities talk. So during the course of our careers, we have education from a variety of sources, right? We have medical mentors, we have our parents. But for me, the real education that I received happened during the 3 decades that I was on the front lines of transplant care. I learned everything that I needed to know about human behavior, about society, about our culture, and then ultimately about myself. And so what I decided to do with these experiences is write a book called Exhale, Hope, Healing, and a Life in Transplant, so that I could document what I had made notes about for decades. But first, before I get into some of that, let me tell you about an email that I sent back in June of 2016, now almost 5 years ago. I went into my office at Stanford and I wrote an email telling my entire team that I had decided to leave Stanford effective July 1st, and that my decision to leave was difficult and multifaceted. The decision was about a lot of things, and so I'll tell you the rest of the story during the course of this talk. But let's talk about the growth phase. First of all, who am I? So as I was introduced, I ran the Center for Advanced Lung Disease and the Lung and Heart Lung Transplant program at Stanford for a decade. And associated with this job are all the usual things, right? lots of papers, directorships, grants, leadership positions, a job that really entailed all the things that go along with an academic position. But aside from that, what was I really like? What was my phenotype? It's hard charging. I was determined, sure of myself. In other words, a lot like you, I would imagine. So why did I pick out transplant? Could have picked any specialty that I wanted. So transplant is a field that for me, when I chose it when I was in my late 20s, it's perfect. It was sexy. It was the cutting edge work. It was innovative. I always called it the tip of the spear in medicine, and that's why I chose it. But what I really want to get across in writing about transplant is what the job's really like. Not just what the job looks like from the outside, but what is it really like to do this job? So when I wrote the book and it ultimately got bought by a publishing house, the publisher asked me, do you think people really want to read about transplant? And I said, this isn't a book about transplant. It's about getting sick. It's about getting well. It's about getting lost. And then it's about finding your own way. It's about life and death. And to me, those are the most universal themes out there, right? It's about learning about yourself. So I know that most of you are on the front lines of transplant medicine. And I write about in the book, what is this job really like to do? And I think that patients look at us in a certain way, and I think it's important we understand this. They come to see us expecting almost a robotic performance, that day in and day out, we do the job in a very mechanical way. But as all of you know, you have bad days, you have bad months, sometimes even bad years. And so I wanted to get across that we're human beings doing a job that takes extraordinary effort. So I want to talk about what we learn doing the jobs. I'm not going to talk about just the good stuff that we learned, but I'm going to talk about some of the bad stuff as well. And I'm very open about it in the book I write. The highs and lows of doing this work were very characteristic of my career and probably very characteristic of your career. Let me talk about a young man named Brian. So Brian was a young 19-year-old that came to see me, had cystic fibrosis, but was developmentally delayed, had cognitive challenges. So someone on our transplant team didn't think that we should transplant him. In fact, he was turned down by a number of centers across the country. And in fact, when we went to the selection committee meeting, you all know what that is. That's a group of people sitting around looking at objective and subjective information about transplant candidates. One of the members of the team said the essence of the evaluation of this young man. Should we transplant someone that is mentally, and he almost said that word, slow or whatever he is? Not too many lungs to go around. So in other words, we were going to take our own value system and apply it to our transplant selection. And this happened early on in my career, and it was never lost on me how careful we should be with these subjective analyses, how carefully we should be as judicious as possible with this awesome responsibility we have to choose transplant candidates, to make those kinds of selections. So we went on with the meeting, and I made the point, a life is a life. Who are we to put value on it? But we do it all the time, right? We do it subconsciously, mostly, but sometimes consciously as well. And we wield this power to save a life or not. And we know that we can't save everybody. But Brian, we did save. He and I ran a 5K race together. He lived 19 years after his transplant, did very well. So the difference between making that selection and not was tremendous for his life. But I also learned a lot about perseverance. I evaluated a gentleman named George for a transplant soon after my arrival in Dallas with my first job. And George had a disease called scleroderma. Difficult disease to transplant, I know all of you know. So we did an extensive evaluation of him. We did all the usual tests. We did all the usual evaluation. But the one thing that we can't measure in a transplant recipient, I've had a hard time teaching this to the more than 20 fellows that I've trained during the course of my career, is, does he have the right stuff? Is the patient tough enough to get through the operation? When the you know what hits the fan, is he or she going to be able to get through it? So George came out of the operating room after we transplanted him, essentially in code mode. And I know that you all know what that looks like. In 2 months, for 2 months, he was up and down, dying one day, almost dying the next day, up and down. And we fought and we fought and we fought. And he went on to live 14 years after transplant. He didn't give up, and neither did I. And he went on to live for a long time after transplant. And he ultimately ran his family's Mexican restaurant, had 2 kids of his own. So with George, that was the beginning of my time on the front lines of transplant. His best was on display, my best was on display. And George is what hooked me to this field, because I knew that if I dug in hard enough, committed hard enough, you can make some great things happen. And I know in a great transplant program like yours, you make this kind of thing happen all the time. What about thinking outside of the box? I think transplant requires that. I think if you go back to the pioneers in transplant, their entire practice was out of the box, right? And so it constantly asks us, both scientifically, humanistically, to think outside the box. Let me tell you about Ken, a patient with idiopathic pulmonary fibrosis who we transplanted. All seemed well. He did great. We thought he was doing great. He thought differently. So he couldn't come off the ventilator. And I told him very calmly, I think your lungs are fine. He didn't think so. He didn't think they were working. And so I couldn't figure out what the disconnect was there. And so finally I realized in talking with him, the problem wasn't with his lungs. It was in his head. It was with how he was looking at his transplant operation. So I tried very calmly to get him to breathe normally, slow down his respiratory rate, and that way we could get him off the ventilator. But he was having none of it. So I used a different technique. It wasn't pretty. I got pissed off. I told him that he had to toughen up. He had to do this now or never. And it was an old school way to deal with a problem, but it was outside of the box. He got really mad at me. His family got really mad at me. The nurse taking care of him got really mad at me, but it worked. So he got off the ventilator. He also went on to live for a long time. And I received a note from his wife saying, gee, it sort of seemed like a bad technique at the time, but it seemed like it worked. And so this is just an example of sometimes we have to throw away the conventional wisdom and do what we think is right for the patient. So what else did I learn about doing some of this work? Fatherhood, probably the most important thing to me. So this is a young woman who I call Amanda in the book. She got a redo transplant after doing really well for 8 years, post double lung transplant for cystic fibrosis. She bled excessively, not atypical for a retransplant, right? Bled excessively for 24 hours, was essentially an hemorrhagic shock. The surgical team was supposed to have been done early that morning, but it was not until 3 o'clock that they wheeled Amanda back to the ICU. Bad start leads to bad finishes. And this was obviously a very bad start. So I had to go talk to her family to tell them that she wasn't going to make it. After telling them this horrible news, this is where the grace of what we do really shines through, what you see in other people. So her father was about to lose one of his 2 daughters. And I was obviously quite distraught by it, upset by the outcome. He followed me down the hall asking me if I was okay. Imagine that. Imagine a parent losing a child, and the father's first reaction is to wonder, if I'm okay, the doctor taking care of them. This is the kind of grace that we need to recognize when we take care of these patients, because it's an amazing display of humanity and courage that I find heartening, even as I talk about it right now. So back then, accepting this kind of outcome, I was not particularly good at. I thought that we could save every patient that we met. And that's obviously foolish thinking. We're a part of saving patients' lives, but we're not the only part. But back then, I took all of these very personally. It was a personal war for me. And when we lost a patient, I took that very personally and thought that that should never really happen. So the field ended up teaching me everything I need to know about all that was good in people, but also I learned a lot about what's not so good. Let me tell you a little bit about some of the tough stuff. So I wrote a Wall Street Journal article in December of 2019, bucking the conventional wisdom that we all tell patients that there's not enough organs to go around. But I actually titled the article, "Supply Isn't the Problem with Organ Transplant." So to tell the story, I talked about a 32-year-old mother of two who was on our waiting list, who I called Emily. So Emily got 3 offers for a lung transplant in less than a week, 3 good sets of lungs. But because of logistical issues with the way we distribute organs and transplant center behavior, none of the 3 sets of lungs were accepted by us. So in one instance, a recent bad outcome made one of our junior surgeons a bit gun shy. And then an emergency aortic dissection came in, so we didn't have a surgeon available. And then the third donor, and we see this a lot in the US, the timing didn't work out. The OPO was very eager to bring the donor to the operating room to get all the other organs procured and couldn't wait on us. So essentially we had to let those organs go. So 3 sets of great lungs, no transplant. So in my view, the issues regarding the way we distribute organs is faulty. And a lot of what I do right now is trying to work on new ways to look at our distribution process. So I was stuck then talking with 2 young kids about to lose their mother for reasons that I thought were all related to the inefficiencies of our system. And I told them that they needed to remember how brave their mother had been and never to forget that no matter what. But that's not a conversation I think any of us really ever want to have. So she died 3 days later. And the family, not knowing all of what we know about the organ distribution system, said it was God's will. But was it? Was it? So for the first time in my medical career, I went across the hall from the patient's room to a supply closet, sat down and burst into tears. It was the first real crack in my armor. It was the first time that I actually ever showed that kind of emotion in the hospital. And I sat there thinking not only about those 2 kids, but about my own as well. I also learned about racial issues. So they're in healthcare. Racial disparities are present throughout healthcare, and they're in transplantation as well. And my group at Stanford wrote quite a bit on this subject. So a silly, and you've heard this story before, a silly argument, a gunshot wound to the head, a brain dead donor, a chance to save someone else's life. So I approached the family about donation, asked them as respectfully as I could if they would help out another group of patients that were on my waiting list and other waiting lists as well. But as I walked down the hallway, you could see grief all the way down the hallway. This was an African-American family that was tight-knit, had their pastor there, and were trying to make the toughest decisions of their life without being able to accept that their loved one was gone. So they decided not to donate. Now, was this a selfish move? I thought so. After I walked away from the ICU at that time of my career, I wondered how anybody could make this decision not to donate. And then I started to think more clearly about it, started to read more clearly about it. And this was a matter of trust. This family didn't have any. We're haunted by the history, particularly in our country, United States, about racial inequities in healthcare. And because of that, this one instance, this one night, this one potential donor, there was no trust there. She didn't trust us, white medical people, so she didn't consent for transplant. And because of that, we weren't able to take a name off of our list that night and transplant a patient safely. So that's where trust really comes to light in our healthcare. And then other things in my career started to change. And I thought a lot about privilege and access. I'm a transplant doctor. I've been one for a long time. My father developed hepatitis C cirrhosis from a blood transfusion due to a hip operation. So at the time, I was working in the field. I was friends with the liver transplant surgeon at our hospital. Called him up and said, "Can you transplant a 68-year-old man?" And at that time, and this is now 20 years ago, it was unusual to do a liver transplant on a 68-year-old. Liver transplant surgeon met my father, evaluated him, said, "Sure." But it got me thinking about whether or not I had exerted influence, my own privilege, my own access to help my father out. And what about the patients that don't have that? So the whole experience with my father's transplant, although wonderful, he did well, it got me thinking about privilege in our healthcare. Also, as I went through the field, and now I work with a lot of transplant teams. I'm essentially a transplant consultant. I coach transplant teams if they're having clinical problems, administrative problems, financial problems, and importantly, team dynamic problems, which, sorry to say, a number of transplant programs have at any one time. So it's gotten me thinking a lot about conflict. It's inherent in our world. Especially, we aren't playing beanbag. Transplants, high intensity, high emotion type of endeavor that attracts people with outsized personalities. It always has. Going back to the beginning, the pioneers of transplant, big egos, big personalities, people that got stuff done. But the problem is that most doctors by nature are conformists. We have people that come in and try to change things, and I'm one of those people. And sometimes we're on the receiving end of scorn by their colleagues, and sometimes it's deserved and sometimes it's not. But conflict is very much something that we have to live side by side with in our profession, especially. In fact, it reminds me of a quote by Aristotle. It said, "To avoid criticism, say nothing, do nothing, and be nothing." It's hard to get things done to revolutionize the kind of care we provide without rubbing some people the wrong way. It's inherent in what we do. It should be accepted that way. And then I'm also reminded of Jeff Bezos, not exactly a philosopher, I wouldn't say, but does run a company you may have heard of called Amazon that said, if you absolutely can't tolerate critics, then don't do anything new or interesting. And I think that that's an interesting way to look at it. So all these fights and disagreements and hospital politics, I think have made me try to understand the effect that has on all of you, on me, on the people that do this kind of work. And it makes me think of a concept that I've recently spent a lot of time reading about called moral injury. I think it's very prevalent in what we do right now in healthcare. And I'm the kind of person that if I find a term that I'm not familiar with, I immediately say, well, what's the definition of it? And so the definition of it is repeatedly expected in the course of providing care to make choices that transgress our long-standing, deeply held commitment to healing. So in what we do, there's misalignment of our value system and our ethics, sometimes with our colleagues, sometimes with the hospitals that we work for, sometimes with the patients. And all of this moral injury is what you see now with regard to the COVID crisis. The system has let down the healthcare workers, the frontline healthcare workers. And what you see is not so much burnout per se, but what you see is moral injury. And that moral injury leads to important things: PTSD, substance abuse, depression, anger, family struggles, spiritual difficulties, all sorts of different problems that I think were prevalent before COVID hit. And then now, I think we would all agree are epidemic. So these are some of the life lessons that I learned along the way with a transplant career. But just to complicate things more, we pick out a career when we're very young. I picked out a transplant career when I was in my late 20s. I'm unfortunately on the back half of my 50s right now. So we experience all these good things and bad things while we ourselves are in the midst of changing. And what kind of changes outside of the hospital happen to us? Well, we have our own families. I had 2 daughters, and one of the big decisions for me for leaving the front lines was they were growing up and I was missing a lot of it. They were getting into their high school years and I wasn't around a lot. And then, as I mentioned, my father received a transplant. So I didn't look at the job the same anymore because I was on the other side of the healthcare equation. I was a family member supporting someone who I loved get his own transplant. So now I looked at everybody that I cared for as somebody's father, somebody's mother, somebody's kid, and that changed the job for me. And then ultimately, he lived 12 years after transplant, and I had to learn about what death looks like in a family member. And it's been said before, death is the great equalizer. And this is a passage from the book that I won't read to you, but basically says that, death doesn't announce itself. There's no drum roll. We don't look at it the same way. We don't react to it the same way. But when my father died, this was in 2013, I essentially had no reaction to it. Flat affect, no emotion. That concerned me. That concerned me a lot. And so it got me thinking about how we deal with death every day professionally, but then when it happens in our personal life, we're unable to express any kind of emotion at all. And when we talk about processing grief, that's not processing grief, that's walling it off. And that concerned me quite a bit. I also developed a medical problem of my own. I'm fine. Thank you for asking. I assume you're asking out there. And it got me thinking about being on the other side of healthcare and being on the receiving end of it, and how different that feels, how vulnerable and scary it is. And so put me in the shoes of my patients for the first time. So that changed me. So my career went on from there. We did a lot of great transplants when I was at Stanford, saved a lot of people, did some great work. But then disillusionment for me started to set in. Like I said, we had all kinds of successes there, but I had developed a lot of the traits that led to poor emotional health. And it was all encompassed in a book that I read over a weekend called Speed, written by a psychologist named Stephanie Brown. And I think a lot of you will very likely relate to it because I talk to transplant folks every day in my consulting work. And transplant doctors and nurses and anyone that works in this field have a lot of the common characteristics that attracted us to the field. We make a frontal assault on everything we do. We have a certain degree of arrogance, and I don't mean that in a derogatory way. I mean it in a way that it makes us feel like we can control the outcomes. We're replacing organs after all, and that we are arrogant enough to think that we can take a heart out of somebody and put it in somebody else, and that patient should live. take a lung out of somebody, put it in somebody else, and that patient should live. And we seek this kind of perfectionism in what we do. But this kind of errand is a fool's errand in a lot of ways. And this book really shed a lot of light on what exactly was going on, at least with me, psychologically. So when the deaths do come, and they come in all transplant programs, I'm sure you're familiar with that. But if each one becomes a referendum on who we are as a person or a doctor, that's going to lead to empathy depletion. Empathy depletion means you just can't express empathy time and time again and expect that battery not to run out. And in me, it had run out. So I'd faced a reckoning. I had entered this field a long time ago, but the exhilaration of being a part of saving a life turned out to be no consolations for the losses. In fact, I became more concerned about my own emotional health when I realized I was actually focusing almost entirely on the failures that we had, the so-called failures, the patients that didn't live. And I was not focusing at all on all the successes. And this isn't a new problem. If you go back to Dr. William Osler from more than a century ago, he said that in no relationship is the physician more often derelict than in his duty to himself. And I think that's true. We spend a lot of time caring for other people. We give everything we have emotionally to these people. We give very little to ourselves. And I think that that's a huge issue for us. So let's talk a little bit about burnout. First of all, the terminology. I can't really stand this word. I think it's poorly descriptive. I think most clinicians resist being characterized this way. I think it is not very descriptive of what's going on with most healthcare workers. It's obviously a term that's out there right now because of COVID, but I think using the right vocabulary is probably important, and I'll speak to that in just a second. But for right now, let's call it burnout. What are the big four drivers of burnout? The first one is lack of control over work conditions. It's lack of control over hiring, inadequate or lack of control over support staff. It's scheduling issues. There's time pressures, and you all know what that is. It's a lack of face-to-face time with our patients. It's too much documentation time with our friend, the electronic medical record, too much administrative time. But here's a biggie, and this is really prevalent in the transplant hospitals that I work with, is there's a lack of alignment of values between the doctors and their leaders around mission or purpose or compensation or who's in charge. And I think this lack of alignment is a really big factor. I'm seeing more and more of it. And then finally, chaotic workplaces. We all work in them. Lots of different time pressures. There's inefficiencies in our practice. And I spoke a little bit about team relationships sometimes being dysfunctional. So one silver lining of COVID, I think, is there's been a number of responses to these healthcare worker issues. There's been the development of in-person support teams, so essentially psychologists rounding on the staff, talking to them, targeted interventions when necessary. There's been the development of these decompression zones throughout the United States, and I assume in Canada as well, where there's dedicated quiet spaces for staff to take a moment. There's seated yoga, stretching, mindfulness exercises. And then there's support lines when behavioral health professionals can interact directly for crisis intervention with the healthcare worker. I think developing these kinds of peer support networks, we can talk to one another to provide emotional first aid is critical. I think one issue that we've seen in healthcare, and this is before COVID, has been, we've all siloed ourselves a little bit too much. When I first started out in the field, we were very much a big family. I mean, we interacted with each other, we socialized with each other. As time went on, and I don't think it was unique to Stanford, we socialized less with one another. We did our jobs and we pretty much went home and on our way afterwards. And I think that isolated us from one another. So tactics for the individual provider are ones you've very likely heard about. Make sure that the relationships that you have with family and friends stay intact. Spiritual practices for those either of a religious or non-religious bent, and make sure that you cultivate your own personal interests and get professional help when it's needed. I also want to spend a minute, I've talked a lot today about physician issues. I could just as easily replace the word physician with nurse. In fact, I think the problem's more acute with nurses. And I think a lot of the issue has to do with staffing with regard to the nurses' issues. And the ones that I've talked about always keep coming back to staffing. And so a recent report from the Healthcare Financial Management Association that says that staffing is critical and having enough nurses actually saves money. There's less medical errors, falls, hospital-acquired infections, and patient death. And a recent New York Times study, unfortunately, found that because of cost cutting associated with COVID, there's not a lot of elective healthcare being provided during the throes of the pandemic. More than half of the top hospital chains in America had laid off, furloughed, or cut the pay of staff members to save money during the pandemic. That's despite receiving government bailout money. One of the nurses who I talked to said that's the moral injury we're talking about. And the moral injury gets even worse when our nursing staff has left the hospital and seen bars and department stores full of people. Very disheartening. And so one of the solutions that's been put forth by my friend Teresa Brown, who's a nurse and an author, she wrote a fantastic book, by the way, called The Shift, that I can highly recommend to you. It was published a number of years ago and was a bestseller. She left nursing. And she left nursing because, as she said, knowing the system cared more about money than patients ruined it for me. And I think that's a lot of what our nurses are feeling right now. So one minute on transplant and burnout. I've always looked at transplant as the perfect field if you want to burn out. It is the epitome of a bunch of people who are dedicated, mission-oriented, that want to control what's inherently uncontrollable. And I think we as transplant folks need to pay particular attention to this topic. And I was heartened to see at the last ISHLT meeting that there was a symposium that was dedicated to looking at burnout, specifically among transplant issues and other psychosocial issues. That was, I thought, very good news. So I told you a minute ago how much I dislike the term burnout. And I think the reason I dislike it is because it assumes that they're mostly internal factors that are driving a doctor or a nurse to burn out, when I think that's probably fairly rarely the case. Sure, there's mental health issues associated with healthcare workers, and there's empathy depletion that I mentioned. But I'm afraid a lot of the disillusionment in healthcare workers has to do with external factors. There's hospital politics, there's the electronic medical record, there's bad policies put forth. And I think all of this has led to the high suicide rate of really any profession, substance abuse, and then the misalignment of values that I talked about earlier. I do think there is an upside to all this burnout, and I think that there is an upside to the COVID-related problems healthcare workers are having. I think that these providers can hopefully come back stronger with more empathy. The hospitals are clearly starting to pay attention to this problem. Nearly every hospital I work with has a program in place. Some are better than others, but they're trying to address the problem. And I think importantly, it allows the provider to think more broadly about his or her own field and career and how he or she fits into that career. Is it still a good fit? Just because it was a good fit 25 years ago, does that mean it's still a good fit? And I think that that's a healthy analysis taking place. So, reinvention. So, reinvention is hard. It can be fun, but it's hard. And I think Carl Jung had it best when he said that the doctor is effective only when he himself is affected. Only the wounded physician really heals. And so let me tell you a little bit. And again, this is my reinvention. This is not, don't take this to mean that it has to be everybody's reinvention. But my professional life now is I work as a coach, more or less, to transplant programs that are having issues of one kind or another. I do nonprofit and for-profit board work, many of which are in the transplant space. And I write because I think for me, it's an important way to hopefully help the field, but also to express what's on my mind. And Jerry Stahl, a famous novelist that I'm a fan of, says that if you had to live it, you get to write it. So that's what I've done. And I think medicine in particular needs storytelling. I think it's therapeutic for the writer, sure, but I also think it's therapeutic for the reader to share an experience with somebody that may have a similar background, may have a similar life experience. I think also these kinds of memoirs can change social and economic factors that impair care in our system. And I think importantly, especially now, they highlight the disparities that are present in our healthcare. And I think that that's the importance of storytelling. So what can healthcare workers do to stay healthy? So for me, and hopefully by now, I think this is obvious based on my talk. For me, it was the 3 F's that helped me get back on the right track. It was family, it was friends, it was faith. And the enemy really is isolation. When you find yourself becoming isolated from all 3 of these F's, don't be. Connection is the key. Connection is the therapy that all of us need. And speaking of therapy, I couldn't or wouldn't have given this talk 5 years ago. I went to therapy. The end of my time at Stanford and for the few years afterwards, I thought mistakenly at the time when I entered therapy that it's for the weak, it's for the broken, it's for the mentally ill. I had all the usual ways to stigmatize therapy that you probably do as well. I look at it entirely differently now. I look at it as going to the gym, except for your emotional health. I go to the gym every day of my life. I have for many decades. This to me is the same thing. You've got to take care of your mind and body in order to be healthy and to take care of the people that we need to take care of. So we're getting to the end of the talk, but I'm going back to June of 2016, and this is a passage from my book. When it was time to get off my chest, what was the right move for me, what I had decided to do, which was to leave this dream job that I had at Stanford to make a new way. But before I got dressed to go to the hospital, I wanted to look through the box. The box was something that I kept underneath my desk. It was a basic cardboard box. It doesn't look like much. It still sits under my desk. It was filled with cards, thank you notes, wedding announcements, anniversary pictures, people jumping out of airplanes, people snow skiing, hiking, you name it. And some of them were just simple thank you notes saying, thanks for helping. These notes have been uplifting and validating. And some days they're the most important thing that I do that day, to stay connected to this incredible field that we have. Other times, the notes show the kind of grace that I mentioned earlier. These are from patients that we had lost, and the family still decided that they needed to make sure that I was okay. And that kind of grace, I think, is so unusual and to bear witness to it day after day was, to me, the experience of a lifetime. So as I concluded in my book, I finally got to the point where I walked away so glad that I had had this experience, so glad that I was able to do my best, and that transplant made me who I was, and I would never be the same again and didn't want to be. So I did my consulting work for a couple of years, but woke up one January morning, had moved back to New Orleans, and decided I wanted to stick my toe back in. The folks at Auctioner, a consulting client of mine as well, had decided that I could come back whenever I wanted. They were happy to have me. I had trained a couple people from Stanford who worked there. And so I decided to go back in one day and start working part-time in the transplant clinic. So I went to orientation for new physicians. Well, I'd been out of the hospital for only 2 years, but it could have been 20. The names had changed. The faces had changed. Everyone was a lot younger than I was. But what was most remarkable about the experience was that they finally hospitals had gotten to the point where even during orientation, they were actually talking to doctors about work-life balance. And even in the couple of years that I was out of the hospital, I think the attitude had changed, and I think it's changed for the better. And that's heartening to me. That's heartening. So that afternoon after orientation, I went to see my first patient in over 2 years. And I'm going to tell you a little bit about this lady. So she was 55 years old, and she had emphysema, and she was going through a transplant evaluation. She was scared, as you might imagine. And in the midst of the evaluation, she was a 55-year-old African-American lady. In the midst of the evaluation, a similarly aged white guy walks in, and they hug and they kiss and they hold hands. And I didn't know who the guy was. Was it her husband? Was it her friend? I didn't know. It turns out that one of this lady's son had gotten a gunshot wound to the head and become an organ donor. And this lady had decided to donate her son's heart to this guy, to somebody she had never met before. So she already had an understanding of what transplant could do for somebody and what the magic was. So I watched them hold and embrace, both of their eyes closed, tears flowing down, chest to chest. It was her tragedy, his gain, his gratitude. And I was sitting there bearing witness to this after being out of the hospital for 2 years. So I'll read from the book, and I'm going to wrap up this way. I look for the patient's hand, take hold of it. While she grieved for her son, I told her that I understand the hurt, that I hurt for her. My holding one of her hands, her son's heart recipient holding the other. These are the times. I think to myself, it's worth it. The hospital rules, the egos, the burden of the responsibilities. In these moments, as an observer of the best in people, I get what I need, what we all need, the education of a lifetime. Now I see that. I couldn't as well when I was going through the hospital so fast, moving through life too fast. And as I sat there with this group in that clinic room, people I knew nothing about a few minutes before, I felt connected. I felt good. I felt back to myself. So people ask me, what was the job like? I get that a lot, especially as I'm talking to groups about my book. How was it to help people get a transplant successfully? And I answer, it was great. It was horrible. It was the best job in the world. It was devastating. And like you, I've seen great things happen and been a part of making some of these great things happen. I've seen horrible stuff as well. But would I do it all again? Yes, without hesitation, qualification, or condition. And as I write about in the book, I'd probably first have a little ice cream, watch a little Netflix, and take a nap, and then I get right back at it. So to conclude, I'm going to leave you just with a couple words that I think are important as we all go through this life and we try to do this incredible work. Go slowly. Pick up all of what is being taught to you out there. Have your antenna up, because going slowly and appreciating what we get the privilege of doing is the best way to stay as healthy as you can. I want to thank you for your kind attention and wish you the best of luck in your own practice.
Thank you very much, David. That was really just a stunning talk, and gosh, where to start? You've hit on so many things. I'm going to pass over to Jayan Nagendran, who of course you know very well, just to start off the questions. Jayan?
David, thank you for doing this. It's wonderful to see you, and you look well. And you know, a comment I want to make before I ask a question is that on top of all the families you've helped touch, you've also mentored very many trainees who have you know, an international impact. I'm one of them, and you know, I want to thank you for that and that mentorship in doing so. So, you know, I'm kind of 10 years in myself now, David, and certainly there are days that I'm overwhelmed, and I appreciate the story of the type A dissection coming in and also trying to deal with the donor. So not what you would have done differently. I hear the advice of going slowly, but what else could be done in the system? You know, you talked about hiring briefly, but I see that as a big opportunity. You put the most amount of responsibility on a couple of people, and it just keeps piling on. Do you have any thoughts as to how we can improve that?
Yeah, China, and thank you for the comments. I really appreciate all of it. You know, I think the backbreaking part of transplantation is the procurement process, really. I think that's the most important, physically, emotionally difficult part of the entire process. And I know you have a long-standing interest in using the technologies that are available to us to make that process more manageable for the surgical team that is 24/7, 365, being asked to fly out, go around, get organs back. I think that we ought to use technologies that are available to us so that we can flip that script entirely, so that we can de-burden the transplant team and make it so that other folks and the technology can help during that procurement process. Because like I mentioned, I think of all the things that we do in transplant, that 24-hour period from donor acceptance to implantation to the ICU can be made much, much simpler and easier on the teams if we would use all of the things that are at our disposal right now. And I, of course, applaud you for trying to do that. But I think that that's critical. That's one area that we can make an impact now.
I'm certainly glad to hear you say that. I'm certainly passionate about that area. Is there anyone else? Sorry, I have other questions.
Yeah, thank you very much, Jayan, and thanks for that answer, David. And would invite everyone also to turn on your cameras if you'd like, so that we can see you, and unmute if you have something that you'd like to ask. Kieran Halloran is going to ask our next question. Kieran?
Hi, David. I'm one of the lung transplant respirologists here. So first of all, thank you for that talk. That very much resonated with you know, the things that we see here, and I know has resonated with a lot of the things, the discussions we've had with colleagues. So really amazing talk. I just wanted to ask, you had mentioned to focus in a little bit, I wanted to follow up on something you'd mentioned in your consultancy work, that you see a lot of you know, transplant groups that there's not alignment between the mission of the transplant group and the mission of the leadership, of the medical leadership at the institution. And that's something that I think everybody listening to your talk right now would resonate with. I think we're very supported by our medical leadership. We wouldn't be able to do this if we weren't, but we're always searching for new ways to kind of navigate those relationships. So what advice have you given or would you give to transplant professionals who are trying to navigate that, in addition to all the clinical stuff that we're trying to navigate?
Yeah, Karen, that's an important question. And I think, besides all the clinical and the mechanics of doing the job and the financial things and the administrative ways to fix the programs that I work with, one thing there's two things that I've asked the teams to do right away is have the hospital administrators shadow the transplant team for a half a day so they can walk in their shoes, and then do the reverse the next day. Have the physicians and nurses and clinicians shadow the administrators and figure out what they're doing. I think one problem we're having is a lot of administrators in hospitals these days. We don't know exactly what are they supposed to be doing? What are they trying to do? What are their pressures? What are their tensions? If we can just walk in each other's shoes a little bit, I think we'd have a much greater understanding. If they were in clinic with you and you had 25 patients to see, they would stand there and say, I better get this guy another nurse practitioner. I better get this guy another nurse. And I think that they would get it. The second thing that I'm having all the teams that I work with do is hang out together. I have a mandated social happy hour policy. I think that one problem, and this has happened with me in my career, I'm not guiltless by any stretch of the imagination, but the teams that actually get to know each other outside of the hospital perform better. I'm convinced of it. And so I've asked the transplant teams that I work with if they can start regularly scheduling those kind of interactions. Obviously more difficult in the COVID era, but hopefully we'll be out of that soon and they can get back to doing that.
Thank you very much for that. Are there other questions? Maybe I'll just add one too, David. I'm struck by how much of what of a contribution there must be to the burnout, or for lack of a better word you've described, has to do again with misalignment of expectations and misalignment of just the various components of our complicated teams. And the field has changed quickly, as we all know here. It continues to change really quickly. And it's quite frightening to think about going away for 2 years and then coming back in and finding everybody looks like they're 20 years old. But that's a major place where I guess, it's daunting and it's impenetrable sometimes to figure out how you're going to change that kind of structure.
Yeah, no, it is. And it's, I think it's all, one of the important things that I was trying to figure out is ask yourself, what do I do well? What are my strengths? And let's start doing those. And the things that I do less well, let's not do those anymore. And I think it's really that kind of simple equation that we have to ask ourselves when we get to these turning points. And so I kind of focus on the things that I do well right now. And going back to the hospital, I have the luxury of not doing the things that I don't do well and actually focusing on the things that I do well.
Well, on behalf of everyone here, we've had a very nice turnout today, and obviously your talk has been inspiring and has captured everyone's imaginations. And it's very nice to have this kind of a talk, in addition to science and clinical things. And I want to thank you again from all of us. David's book is called Exhale. I personally can't wait to get a copy. And we wish you, a great trip back home. Continued good health and excitement during the pandemic. Thanks again,
Okay,
David.
thank you all for having me. I really appreciate it.